Okay, this is a short presentation on placenta accreta spectrum as a reflection on the Royal Society of Medicine section of ONG meeting held on the 3rd of July. I'm not going to critique anybody's talks or anything like that. I'm simply going to add a little bit of information in a different framework to try and to put together my understanding of this syndrome at the moment. The meeting was chaired by Dafo Jurkovic, and the two presentations that are relevant to this talk are those by Jackie Ross and Eric Jonio. I'm not going to discuss the debate between Mr. Yazbek and Dr. Bede or anything like that. I'm just going to put forward a slightly different view of how we might look at this syndrome from a different point of view. So, this work was largely done in Shanghai Jiatong in the department of Professor Huang Hefeng, and I'm going to refer to some of their work at the end of the video. So, the first point that Jackie Ross made was the remarkable change in incidence of the condition over the past 40 years, and these very high incidences in some places, which are very significant changes from the incidence of this particular complication in 1980. Jackie went on to describe the risk of multiple cesarean sections and then drew attention to this new information from an Australian cohort, which suggests that 3 prior GYN procedures such as hysteroscopy, evacuation, laparoscopy, or endometrial ablation confer an excess risk of 5 for this condition. Okay, and that was what triggered my interest in making this video, because there may be a reasonable explanation for why these matters carry that risk. And at the end of the paper, this was by Dr. Carhill from the Society of Gynecological Oncologists, they declared that the favored hypothesis regarding the etiology of placenta accreta spectrum is that a defect at the endometrial-myometrial interface leads to a failure of normal decidualization. But as always with colleagues, discussing the endometrial-myometrial interface, we don't discuss the great big nerve plexus that separates the endometrium from the myometrium, nor that there's a second nerve plexus in the subserosal. Both were described by Kermit Krantz in 1961. And I had the great good fortune to talk to Dr. Krantz about them before his passing in Kansas, when he died at home in Kansas. And he did all the early work on the innervation of the lower genital tract. And this slide just points out that it's complicated and that it's very rarely taken into account in obstetrics and gynecology, because we're not familiar with the morphology of these nerves. And the reason that we're not familiar with the morphology, we lost it in about 1945, when Robert Lee described the morphology of the pelvic autonomic nerves in 1840 at St. George's Hospital in his back garden of forgotten the name of the street, but there was he did it all in his back garden, had all the great and the good come and look at them, and it wasn't even clear that they agreed that there were nerves there, and it's been a matter of contention for many years afterwards. But when you put them in formalin, you can see very clearly that numbers 8, 32, and 33, which describe the nerve plexi, all that's left of the nerve supply, show that the formalin has a very adverse effect on the morphology of the autonomic nerves. Of course, we don't see them at laparoscopy because they're clothed by the uterosacral cardinal ligament complex, and these ensheathe the nerves. We think that the nerves to the endometrial-myometrial interface run medially along the uterosacral ligaments, and that the nerves to the subserosal plexus run with the uterine arteries as they enter the uterus more laterally. If you look at the morphology, you get the idea that all this bundle of nerves here runs between here and here, converging on the cervix and supplying the bladder and rectum as well. And you might agree that there are different conformations of the uterosacral ligaments. Now, not everybody goes looking for these because they're so keen to look at for different deposits of endometriosis, which is, in my opinion, largely an epiphenomenon. But you might agree that these ligaments are thickened, and these are atypical of stage 4 nulliparous endometriosis, that these nerves, these uterosacral ligaments are thinned and attenuated, and when you section them, you find that there's been significant injury to the nerves. And all of these different appearances, ranging up to unilateral and bilateral absence of the uterosacral ligaments, in fact, are associated with different gynecological conditions, which I'm going to show you now. But I'm not going to go through them in any great detail because we've done them in different videos, earlier videos, and we'll no doubt cover them again in future. We'll just illustrate it in adenomyosis because these are the different types of adenomyosis that we see in Shanghai. A lot more of this one than we would see in London, where there's bilateral loss of the uterosacrals, usually as a result of a second trimester abortion, or this more typical appearance where there's scarred, contiguous uterosacral ligaments that remain in continuity with the uterosacral ligaments and contain large numbers of aberrant injured nerves. This shows the histology for you. Here's the diffuse painless adenomyosis, bilateral loss of uterosacral ligaments and cardinal ligaments, no nerves at all, and you see no nerves in the myometrium and absolutely no nerves in the fallopian tubes. So going back to Dr. Ross's information, the favored hypothesis regarding the etiology of placenta accreta spectrum is a possible injury to the endometrial myometrial nerve plexus rather than just to the interface. And the question is, how does the obstetric and gynecological surgery cause these injuries? Well, it's very clear if you have 1 to 5 cesarean sections, although we intend to incise the lower segment of the uterus, occasionally people do perform an upper segment incision, particularly if there's been previous injuries there. And in South America particularly, it's very common to incise that part of the uterus that presents in the abdominal incision. So it's almost a regular feature to find a upper segment incision, which must by definition damage both layers of the uterine innervation. Whereas the lower segment, as Dr. Eric Jonio said, there are no nerves in the lower segment. It's a very convenient place for us to make an incision from that point of view. And there may be merit sometimes, if there's been multiple cesarean sections, in performing a midline, low midline incision, because of course there's no innervation at all in the midline. Finally, just the thought that if you over-aggressive with your retractor at cesarean section may well injure the innervation of the bladder, but a more effective way of doing that is to apply too much traction at hysteroscopy, evacuation, or laparoscopy to the cervix, because that inevitably injures these nerves, which may supply both the uterus and the fallopian tubes, as well as the bladder. And that may represent the clinical associations that Dr. Ross very kindly pointed out in the recent meeting. So in summary, placenta accreta spectrum is increasing in terms of its instance. It's got both obstetric and gynecological risk factors. That both the bladder and the uterus have got vulnerable nerve plexi, and common obstetrics and gynecological procedures may account for some of the injuries, and that these are largely preventable injuries for the most part. Now, this is just a hypothesis at the moment because we've done some studies in pregnancy hysterectomy specimens in Shanghai in the department of Professor Zhang's pathology on the 9th floor of the building 5. And in 3 specimens with both vesical and uterine mucosa, we had no evidence of innervation. Of course, denervation is a difficult thing to prove at the best of times, and it's a very limited series, but I can say that we certainly saw absolutely no evidence of innervation in those circumstances. So this is just putting the innervation of the uterus and how it may be susceptible to injury in a denervation or innervation context. It's clearly a hypothesis, at present needs much more work, but it's an innovative injury insofar as the site of it, the nature of it, and the extent of it can vary depending on the clinical circumstances. And both obstetrics and gynecological conditions may account for it one way or another. So from this back garden in Fulham, it's always neurological. I hope it's a little novel, something new to think about, and I look forward to it. Thank you for listening. We'll see you again next time.